Michael Pinsky, and along with my co-chair, John Marini, we are going to be chairing this session, which is entitled Applied Cardiorespiratory Physiology, a subject that is near and dear to our heart. John, do you want to introduce?
I'd like to echo that as well. This is an educational symposium, and if you have questions, please ask them of the speakers when they finish their talks. Our first talk today is by Katerina Vaporidi from Greece, and she's going to be telling us a little bit about respiratory rate and some of the interesting things about it.
Thank you very much. Thank you very much for the honorable invitation. So we all breathe because our control of breathing system automatically tells us to take an inspiration. And we have this central pattern generator that makes us take an inspiration automatically, but also regulates whether there will be a passive expiration or an active post-inspiratory phase and an active expiration. Our respiratory center is under the cortical control, and some of us can do actually magic with the air coming out of the lungs with this cortical control of this post-inspiration. But for the rest of the talk, we're not going to talk about this. We're going to talk about critically ill patients. And starting first with the normal respiratory rate responses to changing in ventilatory demands, focusing first as examples in exercise, CO2 rebreathing, and the data we have on critically ill patients, and then the effect of medication. So let's start with exercise. This is incremental exercise. On the x-axis, CO2 production, x-axis, respiratory rate and tidal volume. So this plot is my exercise test. This is a respiratory therapist of our ICU. She runs marathons. I don't actually. And this is of a patient from the lab who has restrictive lung disease. So please note that my tidal volume with incremental exercise increased quite rapidly, plateaued towards the end, while my respiratory rate was stable, low, and started increasing, passing the respiratory rate of 30 when my tidal was above 1.5 liters. And it started increasing sharply well after halfway or more on exercise. Similar pattern in my most fit colleague, a rapid increase in tidal volume, a much slower increase in respiratory rate, only to increase fast when tidal volume did not further increase. And notice the response of the patient who could not increase the tidal volume because of the restrictive lung disease, so she had to increase the respiratory rate much faster and to a greater extent. Similar data were obtained a long time ago in healthy volunteers with CO2 rebreathing. So increase in CO2, and notice the change in ventilation, which is achieved by first a sharp increase in tidal volume, a much smaller increase in respiratory rate. And then when tidal volume cannot further increase, respiratory rate takes the step. This is the shape of tidal volume over respiratory rate. This is an experiment, again, about a long time ago in healthy subjects in mechanical ventilation by my mentor, Professor Georgopoulos. These healthy subjects were first made hypocapnic with pressure support, and then hypercapnic with pressure support but inspired CO2. Notice the change in effort when they become hypercapnic, but also the decrease in effort when they become hypocapnic. But also notice what happens with the respiratory rate. Increases with hypercapnia, but remains very stable during hypocapnia. And moving on to critically ill patients, we published this study some years ago. We changed the level of assist in a proportional mode, so the patients are more freely able to choose the tidal volume. With increasing assist, respiratory drive and effort decreased, but tidal volume modestly increased, but respiratory rate had a very minor change. And this is our data from the next speaker. a study on partial neuromuscular blockade, where they saw with the neuromuscular blockade was aiming to decrease patient high effort, and it actually did so, and decrease minute ventilation. Patient became slightly hypercapnic, but the respiratory rate changed from about a little less than 20 to just a little bit more than 20. So respiratory rate is not a very sensitive, doesn't really change much when we change effort. And in the study I told you before, what we saw is that values in the range of 20 to 30 are all over the place of respiratory drive and effort, muscle pressure, and, oops, wrong slide here. What we can say is that high respiratory rate above 30 is always associated with high drive. What we also noticed is that, and we can confirm, is that respiratory rate and effort change towards the same direction at various magnitude and not predictable, but always to the same direction. And how about dyspnea? In this experiment, healthy subjects were subjected to breathing, to incremental exercise, but also with or without increased resistance. So notice the increase in ventilation, increase in tidal volume, increase in muscle pressure. Here with the triangles are with increased resistance. Notice the small change in respiratory rate, and focus here on dyspnea. This is without resistance, this is with resistance. So notice that very low work rates, so very low respiratory rates, resistance caused the patient to suffer from severe dyspnea. So again, respiratory rate doesn't tell us anything about whether the patient is experiencing dyspnea or not. And let's see how we modify respiratory rate with the medication we give in the ICU. We know that, oops, instead of my figure, there's something else there. Oh. Opioids decrease respiratory rate more than effort, but fentanyl decreases effort more than other opioids. They say that this is likely a cause of the increased death rate that we see with illegal fentanyl use. Now, propofol decreases effort more than rate. Again, there's something wrong with my slide. This is a quite old experiment, and you can see how the tidal volume drops with propofol. Midazolam has a similarly large effect on effort, but minimal on respiratory rate, while Dex, that we're currently using more and more often, has minimal effect on drive and effort, but it may affect respiratory rate by modifying the cortical inputs, modulating respiratory rate. And this is also a common indication for the use of Dex. So my slides are really modified here.
Is that your slide? Is that the one you want?
Yes, but there's several things that are missing. Anyway, let's focus now on the potentially injurious effect of rate if respiratory rate can actually cause ventilator-induced lung injury. So first, in vitro studies, what they have shown is that changing the amplitude of deformation of cells or changing the frequency when the cells are deformated can cause cell death and increase permeability. This part that is actually better shown here shows that the change in deformation or the change in amplitude causes increase in permeability. Notice that they had to change for the same amplitude, the frequency from 25 to 1 hertz, so 4 times higher, while a 50% change in amplitude had the same increasing permeability effect. And you are all aware of the concept of mechanical power. This has been extensively discussed in this meeting. And what has been introduced several years ago is that we don't only care about how much the alveoli is deformed, but also how many times this happens over time. So respiratory rate is in the equation of power as tidal volume. Respiratory rate, the impact of respiratory rate on mechanical power is smaller than that of tidal volume. And indeed, studies analyzing data from the ARDS studies have shown that Increase in driving pressure increases mortality, increases in rate also increases mortality. The effect of rate is about 4 times smaller than that of driving pressure. And because we all love applied physiology in the ICU, let's see how that implications of respiratory rate are translated in our critical ill patients. So, a high respiratory rate. Let's discriminate between spontaneous and mechanical rate. We can have a high spontaneous respiratory rate when we have when our patient is experiencing pain, anxiety, delirium, and this is cortical inputs, so it's what we call load independent. If you modify the ventilator, the patient's respiratory rate is likely not going to change. Then a patient may exhibit high respiratory rate because of chemical inputs, hypoxemia, hypercapnia, acidosis, combined with inability to increase tidal volume. This is a prerequisite. This is what we call a load-dependent high respiratory rate because it will decrease if you provide further assist with the ventilation. And so mechanical respiratory rate. A high mechanical respiratory rate may be the one that we have selected in a controlled ventilation. We would have done so if the patient has high demands and high distending pressure, so low lung compliance, has forced us to use very low tidal volume and compensate with a higher respiratory rate. The mechanical respiratory rate may be high, but not because we set it to be like that, but because the patient is able to trigger the ventilator and have double triggering, or because the diaphragm contracts without the patient control of breathing saying so as a reflex in the form of reverse triggering. So a high respiratory rate is indeed associated with adverse patient outcomes. But I'd like to point out that it is not just because it may increase the risk of injury by increasing mechanical power, by increasing last stress in the form of double triggering, or by increasing dynamic hyperinflation in the case of obstructive disease, but also, and perhaps more importantly, because it is a marker of a severe derangement. The patient has to have VQ abnormalities, increased dead space, high CO2 production, low lung compliance, weak muscles, or uncontrolled pain and delirium. And I think you will agree with me that all of these factors are independent predictors of adverse outcome. So it's not surprising that a high respiratory rate has been associated with non-invasive mechanical ventilator failure and weaning failure. Some examples here from the LungSafe study: increased respiratory rate in survivors over non-survivors, increased respiratory rate in NIV failure compared to NIV success, increased respiratory rate associated with higher mortality in ARDS as mechanical power. And I'd like to, before closing, emphasize on another problem, a non-decreasing respiratory rate and how that may be injurious. Because our control of breathing system will not change the respiratory rate, will not decrease that, it will choose to decrease the magnitude of effort when assist provides adequate or excessive tidal volume. So this is my patient. I had him on pressure support of 5, increased pressure support of 15, and PDI, the amplitude of swing of PDI decreased from 12 to 30, while respiratory rate changed by 1 breath per minute. So it's easy to over-assist the patient, and the respiratory center, the respiratory rate does not protect the patient from that. That is why we can easily have also periodic breathing with excessive assist. Even healthy subjects, like in this experiment, increasing assist actually decreased the PCO2 below what is called the apneic threshold, the level of CO2 that we stopped breathing once when we are asleep or sedated. And that is how, and you all know from cardiovascular medicine that periodic breathing has important implications for the cardiovascular system. So, to conclude, respiratory rate in a capsule, Absolute values are markers of drive and effort only at the extremes and nothing in between what we commonly see in the ICU patients. Respiratory rate increases when ventilatory demands increase, only when there is a limitation in tidal volume increase. It may be affected by cortical inputs to the respiratory set. It may cause lung injury, no doubt about it, but most importantly, it's a sign of severe derangement when we have critically ill patients in mechanical ventilation. And do remember that it does not decrease when ventilatory demands decrease, subjecting the patients to the risk of diaphragm atrophy because they will have to decrease their effort. With that, and on time, thank you for your attention.
Questions from the audience? Katerina, you covered such a beautiful display of the interactions of respiratory rate with various physiological features. One of the things that struck me is that you can't look at respiratory rate in isolation. You have to integrate it with the other factors that are going on, so that if you set a criterion based on respiratory rate, it's not really very helpful.
Yes.
Would you agree with that?
Yes, so it's important not to design winning, for example, protocols or based on absolute values of respiratory rate. We need to integrate it with the clinical picture of the patient.
And normally, we're breathing with a respiratory rate that's quite variable within an expanded range, because we're not stressed and we're not reaching those extremes and limits that you were talking about. So I think that's it's almost like the heart in that way. You get to your optimal stroke volume, if you want to call it that, the tidal volume, and if it's not really stressful to the patient, you can vary respiratory rate. Right now, when I talk to you, I have a respiratory rate of 3, and when I catch you up, it'll be 12. But your presentation was very nice. And
I have a question.
Michael?
First of all, thank you very much. I had just one question, and that is, I agree with everything you said. It's wonderful. But why do you think we see that the respiratory rate goes up early in sepsis without the evidence of metabolic acidosis? Why is the Q-SOFA score, one of the primary measures of it is respiratory rate, when in fact it should be very insensitive to it, except that maybe it's impending major doom and therefore the hypertony is simply a marker of that? Why do you think?
I think there are data that our chemoreceptors are sensitive to not only oxygen and carbon dioxide, but also to catecholamines, nitric oxide, and other mediators that are augmented in the early phases of sepsis.
Thank you.
Thank you very much.
Our next speaker is Leo Heunks, and he'll be speaking to us about respiratory drive.
Thank you very much, Michael. Thank you very much. It's very good to see that so many people stay here for respiratory cardiovascular physiology. I think that's really fantastic. There's going to be a little bit of overlap with Katerina's talk, but I don't think that should be a major problem at the end of 3 days of fantastic conference. So these are my disclosures. I don't think that's anything related to the current presentation. And let me just start with this case. So this is a male that was in our ICU recovering from pneumonia. At that time, pH 742, bicaps 25, CO2 41, PO2 96, and tidal volume for him should be around 480 ml. And look right here at his tidal volumes. 10 of PEEP, 0.6 of FiO2, and 5 of pressure support. And if I start the video, you'll see, well, it's a little bit unstable breathing pattern, but in general, tidal volumes are pretty high. Go on, it's 800 ml, 800 ml, despite low support. And that makes us think, why does this patient have a high respiratory drive? it's not CO2 probably, right? It's not PO2 probably. So why does this patient have a respiratory drive? And when we were discussing that in our group, I went into the literature, and there is some fantastic papers out there. Because you should realize, throughout life, you take about 0.5 billion breaths. And that is to regulate gas exchange, to very narrowly regulate pH. And it's really a fantastic phenomenon, I would say. So I think it's good to go a little bit deeper into the physiology. So first, the definition. I think respiratory drive, what we are discussing in this presentation, is the neural output of the respiratory centers. The respiratory centers, right here. There's a couple of areas right here you will recognize. This is the brainstem, cerebellum. Right here is the nose. Right here is your back. This is an important area, the pre-Butzinger complex. That area contains interneurons that generate the rhythm of inspiration. So respiratory pacemaker cells. And this area is very closely connected to this ventral parafacial region, very close to the cerebral spinal fluid right here, right? And this area contains receptors that are sensitive to H+. And I think there's some great physiologists here in the room, and I have gone through the literature over and over again, but I've never been able to find CO2 receptors. So it would be very interesting to hear if somebody knows if there are indeed CO2 receptors. I don't think there are. So the breathing is controlled by H+. There are other centers right here. So this one controls the rhythm of expiration. So we do have different pacemaker cells for inspiration and expiration. That's also nicely shown here. So pacemaker cells for inspiration in the pre-Butzinger complex, for the expiration, and they have different input. For instance, lung inflation will inhibit inspiratory centers and activate expiratory centers. So one more slide on basic physiology, and then I'll get back to clinical work. So don't worry. So right here, this is the whole pathway for generating the tidal volume. So this is the respiratory centers that get input from the body. I'll show you in the next slide. Oh, sorry, there's more physiology coming up. So this is the respiratory centers, activates the spinal motor neurons, activation of the neuromuscular junctions, electrical activity of the diaphragm, generation of flow, and in the end, there's a generation of volume. So there's a lot of steps from respiratory drive to the generation of inspiratory flow. I think this is important as well. Right here you'll see again the respiratory centers, the pre-Butzinger complex, etc., as we just discussed. So what is the input? What determines the respiratory drive? I would like to highlight 3 pathways. First, chemoreception, as already discussed a little bit. pH is the strongest determinant of your respiratory drive. But also the cortical effects. If you want, you can start voluntary hyperinflation right now. But also people working in neuro-ICU will recognize that quite a lot of patients with neurotrauma are actually hyperventilating. As you're sitting here in this room, especially, I guess, after lunch, the cortex has an inhibitory effect on the respiratory centers. So if there's damage to the cortex, a lot of people start hyperventilating. And finally, and very important as well, there's mechanoirritant receptors in the lung, in the chest wall, in the diaphragm, and other places. And we recognize that as well. A patient with pneumonia on the ER, a patient with pulmonary embolism, but also some of patients with consolidations in the ICU, there's activation of these irritant receptors that provide a positive impact on the respiratory centers, starting hyperventilation. So real quick, strongest predictor of respiratory drive, again, just a little increase in end-tidal CO2 has a huge effect on minute ventilation. And we're not breathing that much because of arterial PO2. Only when arterial PO2 is below 68 kilopascal, it has a strong impact on respiratory drive. I'm going to skip this one. This is what Katerina just discussed. The cortical feedback, I just told you, again, there's an important impact of the cortex on respiratory centers. And this is what I told you as well. Again, cytokines in the lung, infection, do activate these irritant receptors that positively affect respiratory drive. So it says equals, but of course, that's not the case. Respiratory drive and respiratory effort, as will be discussed by Luigi in the next presentation, are different. You can have a very high respiratory drive, but if you have strong respiratory muscles, the effort is still going to be low. So effort is generated by the diaphragm, and if the load imposed on the diaphragm increases, if the respiratory drive increases, you're going to recruit accessory, inspiratory, or even expiratory muscles. I'm sure Luigi is going to cover that. A high drive or low drive may have a negative input. A low drive may be associated with respiratory muscle atrophy, patient-ventilated dysynchrony, and sleep fragmentation. On the other hand, a high drive may be associated with self-inflicted lung injury, maybe, I'm not sure, diaphragm injury, hemodynamic consequences, but very important, a high drive, even if effort is low, may result in dyspnea sensation. So it is important, and it's not the topic of this presentation, so I'm not going to discuss that, but I think it's important in our ICU patients to quantify respiratory drive and respiratory effort. And perhaps Luigi is going to address this. Yes, he's going to address this, so I'm going to skip it anyways. Okay, so back to our patient. So we have this patient, and actually this patient is reading a newspaper. He's doing fine. But if we want to, how can we modulate respiratory drive? It's not that easy, right? Okay, so right here, I think this is actually a nice overview, but I'm a little bit biased, but it is a nice overview. So right here, it shows the input to the respiratory drive, right? Cortical stimuli, chemoreceptive stimuli, mechanical stimuli. We can affect, if we want, respiratory effort directly. If effort is really high, Katerina referred to our paper on partial neuromuscular blockade. If your effort is really low, you can do neuromuscular stimulation. But how can we directly affect the drive? Well, cortex, changing sedation. Chemoreception, ECMO, extracorporeal CO2 removal. Mechanical stimuli affecting ventilator settings, and I think that's going to be the most interesting part. Changing inspiratory support, changing PEEP. First, so these are patients, like our patient, recovering from ARDS. At, in this case, 12 of pressure support and pretty high tidal volume, 9.5 ml per kilograms. So what's happening, as most of us would do, I guess, if you just reduce inspiratory effort? So, inspiratory support, pressure support of 6, tidal volume decreases a little bit, but not that much. But at the same time, if you look at electrical activity of the diaphragm, representative effort, you'll see it increases right away. So you reduce support by the ventilator, drive increases right away. There's an increase, the transpulmonary pressure, the pressure damaging to the lung, does not change at all, but the effort generated by the diaphragm increases. So perhaps in this case, just reducing inspiratory effort might not be the best option. Again, drive increases, effort increases, but transpulmonary pressure remains the same. I think this is going to be really interesting. What is the effect of PEEP on respiratory drive? Patients with ARDS, just an example right here. Airway pressure, changes in esophageal pressure. And as you know, esophageal pressure swings represent respiratory effort. So if we, in this patient, increase PEEP from 5 to 15, you will see that swings in esophageal pressure decrease. So for the whole group, 5 of PEEP, 15 of PEEP. Changes in esophageal pressure, right here 10 centimeters of water, quite consistent, increasing PEEP, a decrease in respiratory effort. I've tried this quite a lot in my ICU as well. I'm not sure if it is as consistent as here, but in quite some patients, increasing PEEP reduces effort. And then you'll see, obviously, tidal volume will go down. But now this gets really interesting and complicated. Because if we look at respiratory drive, again, remember, respiratory effort goes down if you increase PEEP. But respiratory drive, in some patients it decreases, but other patients increase respiratory drive, while still effort decreases, right? And it took me a little bit of time to understand what's actually happening right here. But this is, let me skip this one. This is how I understand what's going on. So in your patient, you increase PEEP. Drive could decrease, decreasing effort. I think that could be the case if PEEP increased lung homogeneity, because we just said that consolidation actually activates the irritant receptors in the lungs. So less consolidation, less drive. But in some patients, an increase in PEEP increased drive, but neuromechanical efficiency decreases. How's that? If you increase PEEP, the diaphragm moves downward, becomes at another position on the length tension curve, so it can generate less pressure for the same respiratory drive. And I think that's interesting. Okay, modulation of drive by sedation. Katerina has discussed that, and that's great because I'm running out of time. Very important, as Katerina stressed. I think if you really want to modulate drive, propofol is the first way to go. Don't try opioids. It's not really going to affect your respiratory drive. It may reduce your respiratory rate, but not the drive in itself. So this paper gives a nice overview on the different sedatives on respiratory drive. And of course, but this is theoretical. I think even an ECMO fan like Luigi would not do that, but you can connect the patient to extracorporeal gas exchange or ECMO, reduce CO2, and as Tommaso Mauri did in the study, you'll see the higher the gas flow, sweep gas flow with ECMO, the lower the tidal volume, the lower the respiratory drive. Oops. So I think this actually summarizes it. If you go to the paper, you'll find much more details, but I think this is a topic that is of clinical importance to facilitate a lung and diaphragm protective ventilation strategy. So what I've tried to show you in these 15 minutes, first, there's a chemical, cortical, and reflex feedback to the respiratory center. So when you have a patient with high respiratory drive in your ICU, just go through the 3 pathways and see which one which might play a role in the high drive, and you could actually modulate. The high drive, so high and low effort may also induce lung and muscle injury, and I think it is important, but Luigi will go into that it is important to modulate drive and try to modulate accordingly. Thank you very much.
Thank you very much. This lovely presentation is up for discussion. Well, I'll ask just a quick one. As you probably remember, with extracorporeal membrane oxygenation system that was used as ECOR, the CO2. Luciano Gattinoni, during his fellowship with Ted Colabo at the NIH, demonstrated in sheep that as they progressively increased the amount of CO2 excreted, taken off by the lung, it was directly proportional to the decrease in minute ventilation, to the point that if 100% of the CO2 production was taken off by the lung, the animal became apneic and hypoxemic and crashed, but if you put them on oxygen CPAP, they'd be better. So how do you link that CO2 load of extracorporeal membrane oxygenation with what we see clinically when people are on ECMO, because we're also removing CO2 with ECMO devices.
I think but maybe Luigi is even better suited to answer this, but what we have seen, changing the CO2 with VV ECMO, I mean, some patients actually, minute ventilation goes down, but some patients, especially the patients with less compliant lungs, I mean, still maintain a high respiratory rate, still maintain a high minute ventilation. So I think it nicely shows the complexity of the regulation of breathing. Again, there is patients, and that's what we recognize, right? There are some patients with pH of 750 and still having a high respiratory drive, respiratory effort, and that is because it is not just chemoregulation. There's other factors at play.
Leo, Leo, over here.
Yeah.
Hello.
Is there a question there?
There's a question. Oh, there's a question back there? Okay.
Yes, thank you for your very nice presentation. I'm over here.
Yes. Over there, yeah.
Well, I was about to ask if the patient is on continuous renal replacement therapy, would you use that as a tool also to reduce the respiratory drive? But actually, you answered that question already when you told that when the patient have a pH of 7.5, they still have that drive.
Yeah, so I don't think that renal replacement therapy, of course, in itself is used to modulate respiratory drive, but it could. I mean, if it changes like the chemoreception, it will. But again, I think, and that's what you recognize from your clinical practice as well, there's a lot of other factors that are at play. Again, there are patients with pH of 750, 755, with still a high respiratory drive. In that case, well, first consider if there's a lot of input from the cortex, or if there's something you can do in recruiting the lung or whatsoever.
Question over there. Can you take the microphone to it, please? On the other side. Quick question, please.
So can I ask you a quick question, both gentlemen? Is there a CO2 receptor or no?
I haven't been able to find one. As long as you keep the pH constant, you can change CO2 all you want, and I don't see anything.
So that's why sometimes people say, well, CO2 is too high, et cetera, et cetera. But I think if your pH is 740, it's not playing a role in
But
itself.
in the studies in which you do dynamic changes in CO2, you see the exact reciprocal dynamic changes in pH.
Exactly, yeah. So it's very hard to control pH and differ CO2. Sorry.
Hello, Benjamin from Chile here. Thank you for your presentation. I was quite intrigued about the relation about PEEP and respiratory drive and effort, that sometimes you take them as a unit, but as you shown, is a different component. So how would you explain those differences in the population? Will you explain by body weight, by disease? Do you have any hypothesis or why the effect of elevating PEEP reduces the drive in some people and in some others not?
Well, I think what I try to explain is if indeed with PEEP you can recruit the lung, there's less consolidation, there might be less activation of these irritant receptors, so there's a reduced input to the respiratory centers, but this should not be offset by, say, a more inappropriate position of the diaphragm on the length tension curve. So I think it is really complex, but I really understand if drive goes down and the lung becomes more recruited, that there is less activation of the irritant receptors in the lung. I think that's the major thing that's ongoing, actually. But I think if you want a paper, it's a paper from South America. It's a fantastic paper. So,
Okay. One more question quickly.
Well, very brief remark. We do have CO2 receptors in the lung, which can discriminate carbonated drink from other acid drinks. It's a carbonic anhydrase working sensing system.
I would really love to see the paper because, I mean, but it's a little bit of an academic discussion, but we are here with academics, so that should not be a problem. But still, I mean, there's diffusion of CO2 into the cell, but at some point it has to bind to a receptor, right? And then, as far as I saw it, if you clamp the intercellular pH, nothing is going to happen. But I'd love to see the paper. My Twitter was on the thing. Thank you.
Leo, thank
Send me
you
a
very
copy
much.
of
It
it
was
too,
an
please.
excellent presentation, and I think we have to move on. The next presentation is by Professor Luigi Camporota from the UK, who's going to tell us about effort again and respiratory drive.
Thank you
Luigi.
very much, Professor Marini, Professor Pinsky, and thank you very much to you all for being with us. So I've got no conflict of interest for this talk. And the question is, why should we think about respiratory effort and measuring it even better? We have seen from previous presentations that often what we see in terms of the respiratory pressure on the ventilator will not necessarily reflect what the patient is actually doing. And so we have the problem that we might be giving too much ventilation, too little ventilation. This can cause patient ventilatory synchronies and all the issues that can derive from that. Will cause hemodynamic compromise, because now we have changes in pleural pressure, which will affect the way the cardiorespiratory interaction will happen, and obviously will affect the lung and the diaphragm. And there is this concept of patient self-induced lung injury, again, due to that. And here we have two issues. We've got a situation when the patient is on the ventilator can have very high inspiratory effort despite of the ventilation, so we've got under assistance, and that can cause increased lung stress, so the total transpulmonary pressure can affect lung perfusion because the patient is taking deep inspiratory effort and increasing the pulmonary blood flow, and therefore if there is capillary leak, more pulmonary edema, and can cause asynchronies and clearly diaphragmatic damage because the diaphragm is working very hard. The other side, there might be the other point of over-assistance, which may lead to muscle weakness, atelectasis, and diaphragmatic atrophy, and obviously will impact on the outcome. So this is the issues when we start thinking about ventilation and spontaneous breathing, because now we've got two pumps essentially working together. And now the pressure in the respiratory system is essentially the airway pressure plus the absolute muscle pressure. So now we've got two pumps working in almost with opposite pressures. And if we go back to the equation of motion, so the pressure generated in the respiratory system, we've got a ventilatory pressure there. And then we have, obviously, the tidal volume times the elastance of the chest wall. So it's important in terms of the effort. And there was a question earlier on about body shape, how the chest wall can affect the effort. And clearly, this swings in esophageal pressure and the total PEEP, as Leo just said. So the question is, how are we going to do it in clinical practice? Clearly, there are two components, as we said, the airway pressure that we can simply look at the ventilator, and I'm not going to say any more about that. And clearly we need to measure the muscular pressure, so the inspiratory effort generated by the patient. And we can choose two different ways of doing it. We can either use esophageal balloons, and we'll show some ways of doing it, or we can use the ventilator to evaluate and estimate what might be the inspiratory effort. So if we start with this idea that when we look at pressure alone on the esophageal and look at the inspiratory effort, or we can start looking at more complex way of estimating effort, which is to do with not only with the pressure, but also with the volume. So then we talk about work of breathing. And here we have two issues with work of breathing, because one work of breathing can be associated just with the change in tension, so without generating any volume. Or we can have the expressed as a pressure over time, so pressure time product. And so this is quite important. But I'm going to say something about the inspiratory effort to start with. So this is a patient you can see is not very well, very tachycardic. Professor Pinsky will not be happy about that. Always says tachycardia is always pathological. In that case, it was. Saturation very low, but you can see the respiratory rate is quite depressed, very low. But you can see the swings in esophageal pressure are very large. So this patient is doing really high inspiratory efforts. Now, when we think about assisted breathing, we are thinking about the machine, so the ventilator that is pushing the lungs and the chest wall, generating a positive pleural pressure, and then the respiratory muscles that are pulling the chest wall, generating a negative pleural pressure. So between this pull and this push, we have the total pressure of the respiratory muscles, and you can see the difference between airway pressure and esophageal pressure is the transpulmonary pressure, as we know. And you can see here that when we talk about delta pleural pressure, can be estimated really well from a delta esophageal pressure. If we see the next one here, this is a little bit more complicated, but if you stay with me 1 second, I'm just going to say that what determines the esophageal pressure, or at least the swings in esophageal pressure, is a little bit more complicated because it's not just the effort as such, but there is the interaction between two things. So we've got the airway pressure that needs to push the chest wall, so very important, the chest wall. And at the same time, we've got the muscular pressure that needs to pull the lungs. So now the interaction between elastance of the chest wall and elastance of the lung are very important. So you can see it's a little bit more interaction between the patient and what the ventilator can do. So how can we do it? That now, one of the things that we are interested in is measuring the muscular pressure. Now, the muscular pressure is essentially the pressure of the chest wall minus the pressure in the esophageal. And I can show you, if we think about what the pressure might be, it will be the tidal volume multiplied by the elastance of the chest wall. Now, we can measure it by giving a muscle relaxant or essentially sedate the patient, or we can just estimate it as a 4% of the vital capacity. And then we subtract the esophageal pressure. So that's the muscular pressure there. And you can see that we can do it like that. So this is a esophageal swing there in red. This is the flow of the ventilator, and you can see that this is in yellow is the theoretical recoil of the chest wall. So the chest wall goes up, and so essentially what you see at zero flow, the esophageal pressure goes down, the relaxation goes up, and essentially what the muscular pressure is the difference between these two, because the effort has to be to push the chest wall and change the pressure within the pleura. But as we said, it's not very sensitive, and sometimes using something like a pressure time product could be useful. But one of the issues is it's not really applicable in a clinical practice unless you're Katerina all the time. So I'm going to show you later on something that we can use at the bedside, much more practical. But I think it's useful, given that we are in a physiology session, to talk about this pressure time product. So again, same diagram, flow at the top, esophageal pressure at the bottom. You can see is spontaneous breathing because the esophageal pressure goes down. So this is the elastic recoil of the chest wall. And now you can see here that the pressure in the esophagus has to go down before the flow goes up. So now, if there is effort before in inspiratory flow, that usually indicates, in the absence of expiratory muscle activation, intrinsic PEEP. Okay, so now we've got a certain amount of effort that is spent without any change in volume or flow, just to overcome intrinsic PEEP. So now what we can see, if we shift this one down to where the flow starts becoming positive, we can see two things. There is an amount of work that the patient needs to do to overcome intrinsic PEEP. And then now here, if we fit the elastic or the elastance of the lung, we can further see something to do with elastic work and something to do with resistive work. And essentially now, this is the entire effort of the patient, something that we can't see, this one, because it doesn't generate any volume, and this one can be due to other things like the tube or the airway bronchoconstriction, and this one is due to the elastance. Now, let's pretend we are in normal clinical practice, as we normally are, and we want to use just the ventilator to monitor muscle pressure. So what we can do two things. We can use just simple occlusion maneuvers. So first of all, we can do an end expiratory occlusion maneuver. So this is at the end of expiration. We do an occlusion, and then the patient will take a breath and will generate a negative airway pressure. Now, if we take that delta between PEEP and the most negative airway pressure, we call it delta occlusion pressure. And if you multiply that delta occlusion pressure by 0.75, that will give you an estimation of muscular pressure. You can see this has been validated using esophageal balloon. So it's fairly simple. You can do end expiratory, measure it, multiply by 0.75, and you have an idea what the pressure is. But the problem is not that simple, unfortunately, because we are measuring the global effect of the pleural pressure, not the local effect. And as we know, if the lung is collapsed at the bottom, the lung stops behaving like fluid and becomes a solid. What it means is that the pleural pressure that we see in the consolidated area is much greater than the one we see in the normally ventilated area. So there might be a variation in what you measure, as particularly the way it will impact the lung, particularly in the consolidated area. Is this important? Yes, it is. And this is only one study to say that patients who have high drive and high effort will have a lot of relapses and respiratory failure, whereas the ones who don't, they seem to have less relapses. In this particular case, 0% relapses in respiratory rate. The other thing we can do an end inspiratory occlusion maneuver, a bit like what we do to measure plateau pressure. And in effect, is the same thing. Now, imagine this one. This is the airway pressure. So what we can see on the ventilator, this is the negative pressure, the ones we can't see because the patient is generated, but we can't measure it. The question is, how can we do to see that negative pressure? Now, we can do a plateau maneuver, so end inspiratory occlusion. And now what happens here is that all the negative pressure will become apparent on the top. So when there is equilibration between alveolar pressure and mouth pressure, you can see an increase in pressure. And that increase in pressure is called pressure muscle index. Okay, so the plateau minus the PEEP. Now, this pressure muscle index has been associated or correlates with respiratory effort and work of breathing. And above 6 is what is believed to be associated with high effort. So now what you can see here, you can do a spontaneous breathing, and you have an end expiratory occlusion pressure. You can calculate your muscular pressure. You can then do an end inspiratory occlusion and measure your PMI. If it's within these limits, you're fine, or at least the patient is within target. But if they're not, first of all, consider including a esophageal pressure measurement, maybe think about sedation, or maybe think going back into controlled mechanical ventilation because the patient is too sick and is unable to do. In the last 1 minute, this is my last slide, I'm going to say something that you can look a little bit more in detail. So essentially, this is your occlusion pressure, and you can do two-thirds of the occlusion pressure will give you the transpulmonary pressure. If the transpulmonary pressure total is low, you can see of the effort, and you can see either is very low effort, consider decreasing the sedation, or if it's very high effort but low total distending pressure, maybe you are under assistance. Think about giving a little bit more assistance. And you can see the other way around, so the interaction between total pressure, the inspiratory effort, and the additional maneuvers that we can do. I've got 24 seconds to say thank you very much for your attention.
That was superb.
Thank you.
Luigi, thank you. If there's questions from the audience, please ask them.
I'll scare them all away.
I've got a question for you, Luigi. Why are we concentrating only on inspiratory? The expiratory side, is often active in the clinical setting, and whenever you're using too much PEEP or the minute ventilation requirement goes up, there's some cooperation between inspiration and expiration. Can you comment any on that?
No, you're absolutely right. And obviously we concentrate, as you said, a lot of inspiration, but there is a huge amount of expiratory activation that can happen. And we see that all the time during the, as you say, as defending the lung volume and therefore expelling PEEP when the PEEP is too high. But sometimes when the patients are weak, they try to push first and give them a little bounce of the diaphragm to help them inspire, particularly when they are working at really high level of inspiratory effort compared to their maximum. So I think the expiratory muscle activation is really, really important. Yeah.
It's also very important because it opposes PEEP, which is usually an effect that we're trying to keep the lung units expanded. The extra expiratory effort may collapse lung units that you want to actually recruit in that same general area.
Yes.
I had one question, if you don't mind, and that is, what do you, is this argument of what you're describing in terms of the work of breathing going to be similar with profoundly heterogeneous lung disease, such as unilateral pneumonia or something, where we are assuming that the diaphragm and the respiratory muscles are working as a single unit?
No, I think that is absolutely right. It's quite difficult because we use one measure that is a global measure, but as I was illustrating earlier on, this global measure does not represent all the units. So I think that's where combined monitoring is useful, and maybe think about more than one thing. So the total transpulmonary pressure, the heterogeneity, some of the gas exchange, but they're complex issues, but at least we can start making the first step towards understanding a little bit more about the interaction between the patient and the ventilator.
Thank you.
Thanks.
It's now my great pleasure as well to introduce my co-moderator, John Marini, who is from Minneapolis, who is going to present on mechanical power. John?
Yes, thank you, Michael. We've heard an awful lot about power in this Congress, and some of the sophisticated presentations have challenged even some of us who are very interested in this area. I would like to give you a more simplified view of ventilating power and lung protection. Now, over the years, since the years 2000 to the current time, we've progressed from low tidal volumes to low plateau pressures, to high PEEP open lung approaches, to low driving pressure approaches, to low ventilating power, to low driving power, and now to cumulative injurious strain, which we believe is the indicator that's most closely related with ventilator-induced lung injury. If we focus only on low driving pressure, then we may be making a mistake. Driving pressure definitions are these. If you take the plateau pressure minus PEEP, you get the driving pressure. It's the ratio of the tidal volume to compliance. And the rationale is that it's the tidal volume normalized to the capacity of the baby lung. But unfortunately, it is not the capacity of the baby lung that we're looking at, but simply the inflation characteristic. I'm not saying it's useless. It's actually very helpful, but the driving pressure times frequency may be something that we can use as a quick and easy way of thinking of how to track the injurious components of mechanical ventilation. By taking account of its rate of repetition, we can use driving pressure, and this has been elegantly presented and published by Costa and colleagues from Brazil. Maybe all you need are driving pressure and frequency. In this paper, you might conclude that would be true because of a statistical association between what you are trying to look at and this simple indication of driving pressure combined with frequency multiplied by a mathematical factor. But you have to ask yourself physiologically, can any pressure acting alone cause ventilator-induced lung injury? Now, Bertrand Russell said at one point, the whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people are so full of doubts. I'm sorry, I'm probably one of those fools, but I am actually quite concerned that we're on a bit of the wrong track by looking at driving pressure alone. Pressures by themselves, static pressures anyway, do not cause motion or damage, and neither do the differences between static pressures, such as plateau pressure minus PEEP, which are both static pressures. That pressure difference is important, but not because it's fundamentally related to the ventilator-induced lung injury. Any airway driving pressure alone, whatever we can measure and calculate, does not account for the diversity of regional damage, and I think we all know that because transpulmonary forces are very important. This is an essential slide, I think. If we're thinking about the damage from a given driving pressure, it depends on the associated lung unit compliance and tidal volume. In other words, not only the driving pressure, but the volume change associated with the driving pressure. On the top panel, you'll see that with a compliant unit, you increase to 25 centimeters of water from 5 centimeters of water PEEP, you have a driving pressure of 20. In a non-compliant unit, you do the same thing. Here you have a small volume change, a low energy input, and a tolerated strain being the lengthening that occurs from the baseline condition. Here you have a large volume change, a high energy input, and an overstretched lung unit. The action is at the level of the individual lung units, not at the airway opening. High pressure alone is only partly responsible for damage. You must also add volume to rupture this balloon. You can have a very high pressure, you can have a very high pressure and not break the balloon until you put that extra little bit in, that fractures the balloon, as is shown here. You must add volume to rupture the balloon. You must put energy in. You must overstretch with a volume change and a driving pressure change. You will not be able to inflate or damage this, no matter how much driving pressure you generate with each cycle. With this one, you can inflate it very easily. With this one, you can't inflate it at all. So driving pressure alone is not the answer. Energy input is needed to damage tissue, and that energy input can come from a potential source, be converted to a kinetic source that causes either heat or deformation, depending on whether it's dissipated or is causing structural damage. I don't want to go into great detail because this has been gone through many times in this Congress, but flow resistive and PEEP energy are relevant to the total energy that we compute. If you take the tidal volume and look at the pressure that's required to overcome PEEP, to inflate the lung, and the flow resistive part of the pressure, you get a trapezoid here, the area of which here is the elastic work of breathing, or the elastic energy. If you stay at a fairly low pressure level with any given tidal volume increment, you are generally in a safe zone of energy input. Once you cross what is called a pressure threshold, where you start to fragment elements, then additional energy inputs, additional volume changes caused by additional pieces of the driving pressure increase into an unsafe zone, which is what I'll call damaging energy. Does PEEP make a difference? You bet it does. This is airway pressure in centimeters of water. PEEP will add to the global strain on unrecruited tissues. So you may recruit all the way up here, but the lung units that are not recruited will eventually cross their barrier threshold and be more susceptible to recurring damage with each successive cycle. I said this before in this Congress, and I think it's important that what we quantify as power in the clinical setting is the energy per unit cycle times frequency. This is what has been coined as a term of power, and it's energy per unit time, but it's a very strange type of power. It's the same amount of stress energy per cycle repeated multiple times, and at the end of a minute you add it all up and you call that power. That's not intensity of what's happening. If you then have a threshold pressure which is higher than the peak static pressure that you reach during those tidal cycles, you will not cause much damage, or if any damage at all. If you have a threshold pressure and your elastic pressures exceed that value, then you're going to have a damaging amount of power that's being administered. And if you use a slower frequency but a larger tidal volume, you may deliver exactly the same amount of damaging power but with fewer cycles. The point here is that frequency is important, the threshold for injury is important, and what kind of tidal volume you're using to achieve the minute ventilation that you're interested in. And how fast you do it is important, but the question is, why is that important? Why is the speed? We've said that the PEEP is a contributor. Now, what about the flow? The faster the flow goes, the higher the strain will become because of viscoelastic elements. I talked about this recently, and I don't want to go into it in detail, but viscoelastic tissue drag will amplify the stretching forces and lower the threshold pressure at which any tidal volume is delivered. Flow distributes intercycle power and energy. So we have here an example of ARDS and elastic power, and we have different forms of flow profiles, from sinusoidal flow of spontaneous breathing to pressure preset ventilation to constant flow ventilation. What you notice is that these patterns of flow deliver their power, their energy, and at different times, at different volumes, and there may be some value in looking at flow as a component of what we need to consider when we talk about ventilator-induced lung injury. It's a nice theory, but where's the evidence? There isn't much evidence, but the ones that are out there suggest that the faster your peak flow is, the more likely it is that you're going to damage a fragile and vulnerable lung. If the lung is vulnerable, the faster the flow you push into it, the more likely it is that you're going to damage it. What about power and strain distribution in non-uniform spaces, such as we find in the ARDS lung? I showed you a uniform example before. Here we have multiple compartments. These are arbitrarily assigned various time constant units. The basic principle applies that different units get different levels of power. And this was described in our fairly recent paper with Dr. Gatnoni and my mathematical colleague, Philip Crook. In a mathematical model, potentially damaging tidal energy and power distribute asymmetrically in the heterogeneous environment of the acutely injured lung. And clinician-selected flow profiles not only influence the timing of power delivery, but also spatially distribute the potentially damaging strains of expansion. The principle of power concentration is also very important. If I have a normal-sized lung and I put a global power of 4 joules per minute into that lung and achieve an airway pressure of 30 centimeters of water, nothing much happens. But as I take aerated space away, make it a smaller and smaller baby lung, if I try to do the same things with airway pressure, sorry, it's my fault. If I use the same airway pressure and the same global power, I get a specific power which is much greater for the remaining part of the baby lung. The smaller the baby lung, the more likely it is that power is going to be damaging and faster flows are going to be delivered. If we look at expiration and inspiration, and we look at a normal-sized lung represented by these 3 contiguous circles. At end expiration, we have this configuration. At end inspiration, we have that configuration. Then we start to damage, and we get fewer lung units to take the tidal volume. At end expiration, we may not see much difference in the size of the lung units or any gas trapping or auto PEEP. And when the lung is severely affected, then you may get end tidal hyperinflation. And this has become a focus of intense interest in recent papers. So when we talk about power and determinants of Vili risk, it's damaging energy per tidal cycle. And that's influenced by plateau pressure, peak flow amplitude and profile, amplifiers of stress, which I didn't have time to go into, but which are quite important, the frequency of high stress cycles, and the duration of high power exposures. Those are the mechanical stimuli for Vili that we need to think about physiologically. I'm old enough to remember, I actually met Herman Rahn a long time ago. Herman Rahn, Otis and Wallace Fenn, they wrote the Handbook of Physiology. I think we need to relearn some elements of the Handbook of Physiology. My hats are off to these men, all who have passed from the scene now, but have taught me more than I could ever teach anyone else. So thank you very much for your attention.
John, thank you much for this talk. I have a question for you. I'm just a simple country doctor. I've got a patient on a ventilator, and I think they might have some lung disease, and I have no desire to hurt them. How do I set the ventilator so as to minimize deleterious power? What numbers can I use? How do I do this in a simple way?
Well, the key thing is that some people concentrate on numbers, which you can't do with power. I mean, you can if you know exactly the characteristics of the lungs and the situation and the vulnerability of the tissue that you're working with. But if I'm trying to minimize the amount of damaging power, which I think is the real question, first of all, I minimize the vulnerability if I can. I turn the patient prone, make sure that there's not large areas that are prone to hyperinflation, and others that are more likely to collapse. We can use one pressure to regulate the entire lung and more or less uniformly with whatever we choose. We reduce the demand for ventilation. the patient's demand for ventilation and blood flows are extremely important to reduce the vulnerability of whatever condition they have. Then I regulate the driving pressure, the plateau pressure, according to what is agreed upon right now, 30 and 15 being upper limits of what we might be thinking about. And if we can reduce frequency and reduce the number of cycles and reduce the vulnerability, we probably have done about as much as we can. With flow, I extend the I to E ratio close to 1:1 so that we have a slower amplitude of the flow profile. I use a constant flow and not a decelerating flow. And that's the best I can do at this point because it's not been studied carefully.
Okay, so did you all get that? Okay. You're going to use, you don't want the plateau pressure to exceed 30, and some people say 28. You want the driving pressure to be no more than 10 to 15. And at the same time, since John has shown and others that the lungs are a viscoelastic structure, especially when there's lung disease, you don't want the breath to come in quickly because there'll be dyssynchrony, a heterogeneity of inflation, and that'll cause the regional stress strain he showed in one of his last slides. So you want your inspiratory flow rates to be as slow as possible for the same tidal volume, and it'll keep your strain down. So 6 mLs per kilogram is just an invention of the ARDS net, et cetera, based on what they thought, because they only had 6 or 12 NLs in their study, so that's why we used it. There is nothing special about 6 mLs per kilogram. The concept is to minimize the excessive repetitive increase in lung volume above a certain point, which may actually be below 6 mLs per kilogram. The reason why Dr. Marini said that you turn the patient prone is because it causes a universal distension of the lungs so that there is no caudal to back change in overdistension that normally occurs if you're lying supine. And so this is a way of unifying the lung compliance across regions to make it more homogeneous.
Yeah.
Any other comments you want to make on that, John?
Just to say that I forgot to mention permissive hypercapnia. Letting PCO2 range between 55 and 60 is probably preferable so we can reduce the minute ventilation requirement, the need for frequency, and the need for tidal ventilations.
Okay, thank you. Any other questions from the audience? Thank you very much, John. Now it's my pleasure to introduce Emma Bowcock. I'm sorry, I almost said it wrong. Who is presently in Sydney, Australia, and she will be talking to us about right ventricular pulmonary artery coupling, and I will argue that is one of the most important questions you want to assess in a patient with lung disease.
Thank you very much for that introduction, Professor Pinsky, and thanks to the organisers for inviting me to speak on this topic. It's a great pleasure. I have no conflicts of interest, and I'll talk through RV-PA coupling in the critically ill patient. So just to show some echo images of right ventricular injury, and we can see from these images that it's a real spectrum of injury in the critically ill. We can see here this patient has RV dilatation but has got relatively normal systolic function. This patient has acute on chronic cor pulmonale. This patient has acute cor pulmonale. And these are all sort of a bit of pattern recognition. You can see there's dilatation. We've got this thing called McConnell's sign here. This patient had a pulmonary embolus. And here we have a patient that's had a right ventricular infarct with regional wall changes and significantly reduced systolic function. So we can see that this RV injury is very heterogeneous in our group. But one thing that these patients all do have in common is as they progress from this right ventricular injury towards right ventricular failure, at some point along this pathway, they will uncouple from the pulmonary circulation. So what is RV-PA uncoupling? Well, from a very simplistic sort of conceptual perspective, we can think about the coupled right ventricle as one that's able to match its function against an increased afterload. And this is a happy right ventricle. We can think about the uncoupled right ventricle in being a ventricle that cannot adapt to this increased RV afterload and starts to run into a lot of trouble. But of course we can't, we know that the right ventricle is inextricably linked to the pulmonary circulation, and this is beautifully outlined by Garancino and Professor Pinsky in a very nice article in 2017, which I'd recommend reading. But just to go back to some basic physiological principles, of course we can't just think about it as in those cartoon sort of conceptual ways. So let's take the RV pressure volume loop, and this is for illustration purposes. Of course, we know that the RV pressure volume loop is usually more triangular in shape because of the indeterminate isovolumic periods, because it's ejecting into such a low impedance circulation. But we usually read pressure volume loops, of course, from right to left. We'll start here at the end diastolic point, where the tricuspid valve is just closed, and we have isovolumetric contraction, and the pulmonary valve opens, and then we eject rapidly into the pulmonary circulation, and the pulmonary valve closes again. And then as we get isovolumetric relaxation, the tricuspid valve opens again, and the right ventricle fills. So elastance is, of course, a change in pressure for a change in volume. And the slope of the end-systolic pressure volume line is known as the RV end-systolic elastance. And this is, for all intents and purposes, a load-independent measure of RV contractility. If we connect a line from the end systolic point to the end diastolic point, then the slope of this line is the effective arterial elastance, which is a metric of RV afterload, which takes into account both the pulsatile and the non-pulsatile components of the pulmonary circulation. And the ratio of these two metrics, the ventricular elastance over the effective arterial elastance, gives us this metric of RV-PA coupling. So the right ventricle is I like to think about it as being in health. It's a sort of pretty chilled out ventricle. It has a lot of mechanical energy to spare. And in health, we have this, the ES to EA ratio is around 1.5 to 2, and there's very efficient transfer of that potential energy from the right ventricle into the pulmonary circulation. But as we subject patients to increased RV afterload, for whatever reason that may be, the RV has to compensate for that. And it does it in a couple of ways. It has this heterometric adaptation, or the ANREP effect, where it can increase contractility without necessarily increasing its volume. And then a little later, it uses the Starling mechanism to recruit more stroke volume and dilates to maintain that coupling. And we see patients with chronic pulmonary hypertension with dilated, thickened right ventricles, and they're walking around, or they're at rest, when they're at rest and they're not excessively exercising, they're usually doing okay. It's not until something goes wrong that they fall off their perch. But what happens with progressive RV injury and an RV failure is that these Frank-Starling mechanisms are really exhausted, and we get extreme dilatation, and we get that negative systolic and diastolic interaction with the left side. We get RV coronary ischemia, and then the stroke volume starts to decrease. And we start to see this drop-off in RV contractility. And below coupling ratios of around 1, that's when we start to see the signs of RV failure with increased central venous pressure, etc. So the ways that we can measure RV-PA coupling, the gold standard is using a multi-beat method, where we use a conductance catheter to measure simultaneous pressures and volumes. And then we can reduce the volume to make a family of curves using IVC occlusion balloons or the Valsalva maneuver. And you can see in this patient here, we have the conductance catheter and an IVC balloon. So what this does is enables a series of curves, or a family of curves, and then it's the slope of these end systolic points which make the end systolic pressure-volume relationship and the effective arterial elastance line, and we can calculate RV-PA coupling. And this multi-beat method has been shown to have prognostic significance. It's relatively small studies. There are 26 patients in the study by Stephen Chu, with a cutoff value of less than 0.65 for this multi-beat ES to EA ratio predicting clinical worsening. And in a study by Richter et al., 38 patients, again, similar cutoff values, 0.6 to 0.7, showing that these metrics really do have prognostic significance. in patients with pulmonary hypertension. But of course, these multi-beat techniques are quite difficult, and to bridge that gap between bench and bedside, we need simpler techniques. And using PA catheters rather than RV conductance catheters, and using MRIs to derive volumes have been looked at over the last decade or so. And this is a busy slide that I apologize for, but I'm going to try and reinvigorate my trigonometry knowledge to explain this. So essentially, we can use a single beat method where we don't need to have the IVC occlusion balloon in, and we can generate that. We can use the pressure method. Okay, so with this method, what we do is estimate a maximal pressure, and then the line that connects this maximal pressure to the end systolic point, the slope of this line is the end systolic elastance. And as we can see, that's calculated through trigonometry by the end systolic pressure to P max difference, and we divide that over this stroke volume. So change in pressure for a change in stroke volume, and that's the slope of that line. And the effective arterial elastance is calculated by connecting the end systolic pressure by the end systolic pressure over the stroke volume, and that gives us the slope of the EA line. And because there are common volume terms, then we can cancel them out, and the coupling ratio simplifies to the P max over the end systolic pressure. And the P max can be calculated by methods described back in the early 2000s by extrapolating, doing sine wave extrapolation of this RV pressure curve in early systole and diastole. We can also use a volumetric method where we're no longer calculating this pressure maximum, but we're assuming that the volume in the right ventricle under zero loading conditions is zero. And then we can draw a line from this end systolic point to this theoretical zero, and of course this then cancels just to being end systolic pressure over end systolic volume. And again, EA can be calculated the same way as previous. And because we have common pressure terms, this then cancels out to give us a simplified volumetric assessment of RV-PA coupling. There are obvious limitations to this and a lot of assumptions that are being used in this simplified method. And number one, of course, being that assuming that this volume in the right ventricle is zero under zero loading conditions, and we know that that's not true in patients with pulmonary hypertension especially. And so using this method, we will underestimate coupling. And similarly, if we're using pulmonary artery catheters and assuming that the mean pulmonary artery pressure equals end systolic pressure, then we know that that underestimates that, and we're going to overestimate coupling. And finally, the key question that comes up a lot is, isn't the stroke volume of end systolic volume just telling you the same information as RV ejection fraction? And of course it is in some ways because it's mathematically related, as you can see here. But the relationship between right ventricular ejection fraction and these coupling metrics is nonlinear. And the red lines here, and this is in a paper by Rebecca Vanderpoel's group, the red lines signify lines of prognostic importance, so ejection fraction of 35% and coupling metrics of less than 0.5. And you can see this nonlinear relationship in this larger physiological range of the coupling metrics. And so the question then is, could these coupling metrics be more sensitive to detecting earlier RV dysfunction? And this simplified metric has been proven to be prognostic in subsequent studies by Rebecca Vanderpoel's group. So just moving on now, just in the last 4 minutes, sorry, I'm slightly running out of time, the bedside surrogates of coupling. So there's a few different echo metrics that are used to be applied at the bedside. And the TAPC really is a measure of RV contractility or a surrogate of that, and your pulmonary artery systolic pressure is a surrogate of afterload, and there are other indices that have been described. So this ratio, this simplified ratio of TAPC to pulmonary artery systolic pressure was validated in 52 pulmonary hypertension patients by Tello in 2019. And what they found was comparing this to single beat methods, which they used a cutoff value for uncoupling of 0.8. They found that at this cutoff value, TAPSE to pulmonary artery systolic pressure emerged as the best discriminator to detect uncoupling, and they found cutoff values of 0.31. They then looked at these cutoff values and found that, in fact, patients with TAPSE pulmonary artery systolic pressure ratios of less than 0.31 is associated with higher mortality. But interestingly, in this study, the ratio didn't particularly correlate too well with invasive single beat methods of coupling. So then this brings to the question of, are these coupling metrics superior to our standard methods? And this paper, this very nice paper in 2021 by Smizer et al. Of 110 patients with heart failure, compared all of these surrogates. And they showed that TAPSE to pulmonary artery systolic pressure has really similar but almost slightly inferior correlation than TAPSE alone, or fractional area change, which is another metric that we use commonly to assess RV function. And certainly the TAPSE to pulmonary artery systolic ratio didn't perform superior to just TAPSE alone in predicting mortality. But it did, I just note they both did perform better than just pulmonary artery systolic pressure alone. So what about data in the critically ill? There are a couple of studies looking at these parameters, one by Zhang and colleagues in 2020 of 180 mechanically ventilated septic shock patients. The overall one-year mortality in this group was 36%, and there was a few exclusion criteria, and all of the patients were mechanically ventilated. And they found by ROC curve analysis this cutoff value, which independently predicted mortality. After multivariate analysis was a cutoff value of 0.5, and the Kaplan-Meier curve shows that patients that had values lower than this had higher mortality at 1 year. And the Dolto study from Quick Care back in 2020 showed that in COVID patients, these parameters also have prognostic significance, with the TAPSE pulmonary artery systolic pressure ratio as well as the PF ratio both emerging as independent predictors of mortality. This is unpublished data. We've recently looked at over 1,000 patients in our unit using the National Echo Database of Australia and using tertiles to categorize these ratios. We can see that those in middle tertiles and lower tertiles with TAPSE, with coupling metrics less than 0.39, certainly seem to have higher short and long-term mortality. Sokios et al. Outlined this nice way that we could maybe phenotype RV injury better at the bedside, and you can see that they included these coupling metrics now, and this TAPSE ratio from the D'Alto study was included at 0.63. So I guess the clinical application of this could be, this is a patient with ARDS who's clinically shocked at day 1 and has these signs with paradoxical septum motion, RV dilatation, so signs of acute cor pulmonale. But the TAPSE in this patient is preserved, in fact, a little higher, but the ratio is quite low, it's 0.5. So does this represent early uncoupling? And I guess the question as clinicians at the bedside is, can we prevent this uncoupling? We can see the TAPSE ratio significantly decreases, in fact, halves. The TAPSE goes down a little bit. And can we prevent some of this this RV failure progression by trending these metrics at the bedside? And are they superior to standard metrics? And I'll just finish in the last 10 seconds, if I may, Professor Pinsky, by saying that these roadmaps have been looked at in chronic pulmonary hypertension by Tello, and they show that as these coupling metrics, that the RV has pretty good reserve until these coupling metrics, which is this line here, drop below about 0.8. And at that point, the ejection fraction, as well as the RV size and dilatation, starts to happen. But we don't really have this blueprint in critically ill patients. And of course, what are the effects of loading conditions and the untrained right ventricle on the pattern of change of coupling metrics in the ICU? And we are starting to look at some of these maybe hybrid techniques to see whether we can start to validate these things a little better. And in summary, I think we know that RVPA coupling is of a very important prognostic prognostically. Future prospective research is needed to establish its diagnostic and therapeutic role over standard parameters. And I think validation studies in the critically ill with these bedside surrogates against invasively derived coupling metrics is very much needed. And I'm sorry to go over again. I thank you very much for listening.
Thank you. This paper is open for questions from the audience. I just want to underscore one of the things that you said, but I want them to hear it, and that is that the elevated pulmonary artery pressures, of course, are bad for the right ventricle. However, for the same elevated pulmonary artery pressure, you can have a normal functioning cardiovascular system or one near failure, because it isn't the pulmonary artery pressure alone, but it's the ventricular arterial coupling of that right ventricle with the pulmonary artery that determines what's going to happen. Regrettably, except for pulmonary hypertension patients where we have specific anti-hypertension drugs that we give, angiotensin inhibitors, et cetera, we don't really have for ARDS at the moment primary pulmonary vascular disease treatment methods yet, but we can at least follow it. Are there questions other than that? So what would you recommend to the doctors in here if they have a patient who doesn't have a pulmonary artery catheter in, and they're on mechanical ventilation, and they have access to echo?
Yes.
How would you assess whether or not the patient was doing well from the perspective of right ventricular function?
Thank you for that question. I think it's important that we don't use one single modality for assessing the RV, so using metrics that look at the longitudinal function as well as its radial function, and that would include TAPSE and fractional area change, but also looking at perhaps less load-dependent measures, using free wall strain if you can, but and then, of course, linking that to the pulmonary circulation. So really important that we try to get that window into what's happening in the pulmonary circulation, not just using pulmonary artery pressures. We know that they're estimated when your RV is dysfunctional. So using pulse wave Doppler through the right ventricular outflow tract and looking to see whether there's evidence of raised pulmonary vascular resistance. And I must admit, I have started using some of these coupling metrics and trending them, but we need more data to see whether that's a good thing or not. Hi there.
I'm glad you mentioned RV strain. Do you think it would be a better ratio instead of TAPSE to use strain over
pulmonary artery systolic
yes,
pressure?
over the
I do. I think it has real promise. I think there's some studies that Rebecca Hahn just talked about. I forget the name of them, but I think it's looking at patients with functional tricuspid regurg after tricuspid regurg repair. Those metrics of RV free wall strain over pulmonary artery systolic pressure seem to be highly prognostic.
With tissue Doppler imaging, we can now get regional strain and very close methods, and it's a very exciting way now that with echo we can get into the actual function of the heart. The problems are that the interventricular septum is a very complex thing, so you only have to focus on the free wall of the right ventricle to do your strain measurements, because otherwise there's too much interference of the contractility. But watch this space, because in the future we're going to be talking about using right ventricular free wall strain as an easily measured parameter to follow how the right ventricle is handling the pressure load that's there. Thank you very much.
Thank you very much.
Well, to conclude the session, we're going to be talking on the topic of the microcirculation, how the systemic microcirculation can adapt to low oxygen supplies, by Matthias Hilty. Matthias, please.
Thank you, Chairman, for this kind introduction. And I must say I'm really excited that we can conclude this nice Congress with a session on cardiorespiratory physiology. That's really nice. And thank you for bearing with us until the end. Critically ill patients in our ICUs, they often suffer from circulatory shock. And circulatory shock, that is basically the lack of adequate oxygen supply to the tissue. And we have heard now a lot about how the oxygen gets from the lungs into the circulation. We have heard about the function of the heart, which pumps the blood into the large vessels. And from there, it goes into the tissue. The tissue is where the red blood cells in single file move through the capillaries, and the oxygen diffuses from the red blood cells to the target cells to enable oxidative phosphorylation in the mitochondria. So that's of course, how the circulatory system works. But the question is, where happens the adaptation of our body to hypoxia? So in the critically ill patients, tissue hypoxia is the problem. How do these components of the circulatory system adapt to tissue hypoxia? And of course, there are a lot of data on the circulatory system adapting to the lack of oxygen. We know, for example, for the pulmonary circulation, of course, the pulmonary circulation reacts to alveolar hypoxia with the Euler-Liljestrand mechanism, with an increase in pulmonary pressure. And if we prolong the exposure, and this we have shown in a study made on the Jungfraujoch, that there is early remodeling of the pulmonary circulation that keeps the pressure high. So if people remain within hypoxic conditions, this increase in pulmonary artery pressure, it will remain constant. Regarding the systemic circulation, and this is actually where the magic should happen to adapt to hypoxia, that is transmitted from the environment to the lung, or could originate in the lung in case of lung injury, of course. The pattern is much less consistent. For example, studies where healthy volunteers have been subjected to hypoxia, they show an increase in cardiac output, some show a decrease in cardiac output. It is really inconsistent, so there is no clear pattern of what happens. And similar to what we do in the ICU, we are measuring cardiac output, blood pressure, and the volumes in the heart and in the vessels to assess what happens with tissue oxygenation. This is really a challenge where maybe we should be looking actually at the tissue and the mechanisms that regulate the blood flow in the tissue. So is there an adaptive response to tissue hypoxia that is an intrinsic function of the microcirculation? So that would be the question that I would ask. And then the second challenge, of course, is we cannot really examine the mechanisms of adaptation that physiologically happen to tissue hypoxia in critically ill patients, because they are much too heterogeneous. There are so many factors influencing patients with ARDS, with sepsis, that we're not able to study the physiological mechanisms. So we need a model for tissue hypoxia, for isolated tissue hypoxia. And that, fortunately, is very easy to find, because we happen to live on a planet with an atmosphere that gets thinner as we go higher. So there is a clear and easy relationship between the altitude above sea level and the atmospheric pressure, which also defines, of course, the pressure of the partial pressure of oxygen that we can breathe in to the lungs, and in the end, the oxygen supply that we can give to the cells. There have been a lot of exciting studies early on to study how does the circulation adapt, the microcirculation adapt to hypoxia. And they have been performed using this model of isolated tissue hypoxia at high altitude by bringing healthy volunteers to high altitude. So in the 70s, it was postulated that there is an increase in capillary density as a response to hypoxic exposure, but this was measured in muscle biopsies. So we took some samples from the muscle, looked at that under the microscope, and of course, there is a question remaining: is it really a change in density, or is it also just a change in muscle volume that would influence our measurements? So it was not really clear if we were seeing actually an adaptation mechanism. And also beyond the capillaries, there is very nice data, for example, on the increase in mitochondrial volume density happening in muscle tissue. And that, again, is a study that we performed in the Jungfrau Joch with muscle biopsies. But there we can really show that the volume density increases, so it's not a confounded effect. But nowadays, fortunately, we don't have to take muscle biopsies to measure what happens to the red blood cell flow in the tissue. So we can use in vivo capillary microscopy, where we indirectly light the tissue with green light, which is absorbed by hemoglobin, and then use dark field microscopy to show the movement of the red blood cells in the tissue. And the sublingual area, the sublingual mucosa, presents a very nice point where we can measure this in healthy volunteers or in patients in vivo. And you see in the images, you can see the individual red blood cells moving through the capillaries. And of course, the challenge here is we have very complex image data. And to extract the actual quantitative measures of oxygen delivery to the tissue from these images, it's not very easy. I won't go into detail here, but we have developed an algorithm that's able to analyze automatically these image sequences and determine independently and quantitatively the microcirculatory diffusion capacity, which consists on the capillary density and the capillary hematocrit, and also the parameters of microcirculatory convection capacity, so the movement of red blood cells, or simplified, the red blood cell velocity. And there is one more trick that we would need to use to discern these mechanisms in healthy volunteers when we then go to high altitude. And that is the fact that in normal people like we are in this room, only a small proportion of the capillaries that exist are actually perfused by red blood cells. So there is a pretty large reserve capacity, and these capillaries, they are perfused, of course, by blood plasma, but not by red blood cells. And there is a way that we also described how to measure this reserve capacity. It's actually quite easy. We can apply nitroglycerin topically to the sublingual mucosa and measure before and after. And this challenge allows to recruit the full capacity of the microcirculation. And by measuring after performing this challenge, we can look at the difference. And then we see the recruitable reserve capacity of the microcirculation. It's also, of course, a non-invasive measurement. So now we have the tools we need. We can actually take our healthy volunteers to the Himalaya, which is, there is a research expedition we have performed to Nepal at 7,200 meters, where we took 40 healthy volunteers to high altitude with the goal to measure in the sublingual microcirculation the blood flow. And of course, there are some very nice upsides to performing this kind of study. It's probably one of the laboratories I have worked with the nicest views ever. This is Camp 3 on Mount Himlung Himal at 7,000 meters, where we had the research tent to perform the measurements, the sublingual measurements. This image shows how the measurements are performed sublingually, and this is, of course, an image of base camp at 5,000 meters. There we still had the nice beds for the volunteers to lie on. In Camp 3, this looked a bit differently. And some things, they happen as a surprise in these environments. Here, the solution of the nitroglycerin froze, but it was, of course, pretty easy to remedy this this problem. And again, the reward, of course, to be in such an environment is enormous. So what did we find? And this is pretty nice. We had echo to measure cardiac output. We could calculate systemic vascular hindrance. This takes into account the viscosity of the blood, changes in viscosity. And our study was one of those studies where cardiac output decreased significantly, going from sea level to 6,000 meters. So as I said, this is really, if you look at the literature, in some studies there is no change, in some studies there is a slight increase. I think this depends on many factors. If you're outside, including your drinking habits and the amount of exercise that you've done. But obviously, this is not how the body regulates its oxygen supply to the tissue. So we look directly at the tissue, and there it, of course, gets interesting. Here on the y-axis, we have the total vessel density. This is the density of capillaries per volume of tissue that are recruited. And we see this here with on sea level to the left and on 6,000 meters to the right. And what is really interesting, we have performed the nitroglycerin challenge at sea level. And the amount of recruitment that was possible of total vessel density at sea level, it was exactly the same as was recruited when the volunteers went from sea level to 6,000 meters. So this shows not only that an important mechanism to increase oxygen availability in the tissue at high altitude in healthy volunteers is the recruitment of capillaries, the increase in capillary density, but also that this recruitment is a recruitment of already existing capillaries. So it's a functional recruitment. It's not a existence of new capillaries. This is how it looks like at baseline and nitroglycerin status, and at sea level and at high altitude. And you see that this here at sea level with nitroglycerin and baseline at high altitude is also in the detailed analysis is a consistent picture. Going a bit higher, so here we have the 6,000 meter measurements which we talked about, and then going higher to 7,000 meters. You have seen the images of Camp 3. There is another aspect coming up, and that is that the total recruitable capacity with nitroglycerin was actually higher than in the other two measurements. So there are two factors. One is that, of course, we spent more time until we did the measurements at 7,000 meters, so it was 4 weeks instead of 2 weeks. And also there was an additional stimulus of the increased altitude. And this might have led to really an additional number of capillaries being grown in the volunteers. So to finish, I would just make one comparison, again going back to the intensive care unit. And this you remember very well. This is for Switzerland, where I'm coming from, the COVID pandemic. We thought that basically COVID-19, it would induce an inflammatory state, which it of course did, and it would impair the microcirculatory function such as sepsis does, in the same way as sepsis does. So we wanted to see this in the microcirculation. We measured the systemic microcirculation using the same technique in our COVID patients, and we pooled the data with 3 centers in Switzerland and in the Netherlands to perform the analysis. So what we have found, and first we thought that there was something wrong with the algorithm. What we have found for all of the functional parameters of the microcirculation was an increase in functionality as compared to healthy volunteers. This was true for the vessel density, it was true for the red blood cell velocity, and also for the capillary hematocrit. So all of these determinants of convection and diffusion capacity went up. So this is not the picture of an impaired systemic microcirculation as we see in sepsis. This is the picture that looks exactly like we have seen in the Himalayas of a systemic microcirculation that adapts to hypoxemia, that here in these patients obviously comes from the lung damage and not from the high altitude. Just as a side note, this is a mechanism that disappeared in patients that had a SOFA score higher than 10. So of course, these adaptation, these regulation mechanisms that seem to be intact in the COVID patients, they fail when those patients go into multi-organ failure. So this is just, I think, a very nice example, and maybe also one of the first such direct examples to show that really this model for tissue hypoxia going to high altitude is really relevant and directly connected to what happens in our patients in the ICU. So to conclude, the microcirculation has intrinsic regulation mechanisms to regulate oxygen supply to the tissue, and the response is to increase capillary density by recruiting capillaries. So it's capillaries that are functionally recruited as opposed to a structural response in the acute setting. And when you stay longer at high altitude and have a very extreme, let's say, stimulus, then neogenesis seems to be possible. And in critically ill COVID-19 patients, this same mechanism was described in the ICU in patients that were not in multi-organ failure. So providing a link between high-altitude research and critical illness. We are, again, performing research at high altitude. So a follow-up study that we have done at Mount Amadablam, just in November 2022, we looked at if intermittent hypoxia provided in a nitrogen concentrator tent would also lead to the same physiological response. And I will be happy to provide you with the results at a later time. Thank you for your attention.
That was superb and very interesting. Thank you. Questions?
Well, I have a thought. Did you have a question? Please, would you answer? You do yours first.
Thank you for this nice talk. I would like to ask you, there is a paper of Sprong which was using nitroglycerin in septic shock, and he observed an increase in the capillary density and increased oxygen extraction. What is your opinion about this paper, and do we apply this? But it's a problem for blood pressure.
This is an excellent question. And of course, as opposed to topically applying nitroglycerin as we did, and we proved that there is no systemic effect of this very small amount of nitroglycerin, not even the ability to measure nitroglycerin byproducts in the blood. So we examined that. If you give it systemically, like in the study you referenced, of course, this could be an interesting modality of treatment of microcirculatory dysfunction in patients when we find this type of dysfunction by actually looking at the tissue, which is of course a great idea. The problem with this in septic patients is that in sepsis, which is a disease of the tissue, and presents with primary dysfunction of the microcirculation, we have endothelial damage, we have disseminated intravascular coagulation, and we have some capillaries that are damaged and prevent flow of red blood cells, and we have hyperperfusion in other capillaries. And by simply vasodilating the arterioles using nitroglycerin, I don't think we can really remedy the damage that was done in the capillaries that are preventing the red blood cells from flowing normally. So this might increase oxygen availability in the tissue to some extent, but it presents the risk to also increase shunt, which happens in the hyperperfused capillaries on the other hand. So this might be the reason that the study you mentioned did not show promising results for the sepsis course in these patients. So there we are actually more focused, I think, by looking at the tissue at preventing over-resuscitation, at preventing measures that harm the patients and they don't benefit from it. And by looking, for example, just at stroke volume, we give fluids, we increase cardiac output, and we're very happy, but in the end, in the tissue, we hemodilute, and we increase shunt, and that's what we should prevent. So I think the value of the microcirculatory monitoring in septic patients is more to prevent harm than to be able to really apply nitroglycerin, for example, systemically. I hope this answers your question.
I had a comment and a question for you. You showed the data on early COVID, where there was actually an increase in capillary flow compared to when it gets really super bad ARDS. So we know as well that early in COVID, we lose the hypoxic pulmonary vasoconstriction response because of an endothelial dysfunction with the lack of signaling, so that there is a marked hypoxemia with just a minimal amount of gas exchange abnormality. Okay. If that is true, then are we not seeing a generalized endotheliitis that's present in the microvascular as well? And maybe what you were seeing in your early COVID patients was just the microvascular manifestation of the same process going on there.
This is a very good comment, and of course it's entirely possible that at least in some part we are seeing this mechanism. Because using this examination, even though we can go into some detail with the nitroglycerin, we cannot discern to the lowest detail the mechanisms below that. So this is of course a very interesting proposition. But the end effect, in any case, is that the body can live with this very high amount of hypoxia, and it will really explain this picture that we have seen clinically of those patients with very low saturations that were actually doing quite well. Thank you for this question.
This is a simple and probably naive comment, but you're looking at tissue that is accessible. Your vital organs, how do you think the microcirculatory systemic adaptation occurs in those? By a similar mechanism, or you understand? I think what you're studying are elements that are fairly close and obviously observable, but the liver, the kidney, heart, and others may have different responses.
That's of course also a very good comment. We know that the sublingual microcirculation or the sublingual circulation is regulated in parallel to the visceral circulation. That's also embryologically the same tissue. And there are studies, for example, in septic shock that show a parallel decline of the sublingual microcirculatory function and the tissue oxygenation in the kidney, for example. So there is a lot of data that shows that we have a valuable insight from the sublingual side, but of course, it is not going to be the same in every organ. It would be very nice to have more points of entry and independently monitor multiple points, and this could be something for the future. But right now, we are at the point where we either look at cardiac output and blood pressure and don't see anything at all what really happens, or we can have one entrance point and really see the physiological mechanisms, and that's already, I think, much better than having no entry point. But that's a very good proposition for the future.
Well, that was outstanding, and I hope everyone enjoyed the seminar as much as I did. And I think we need to bring it to a close now. And thank you for attending, and thank you for attending the whole conference. It was really terrific here.